And in the context of that very nice introduction, I especially want to acknowledge Arturo's patience and kindness in bringing, in me coming to join you. It's a particular pleasure to come with David because we've been able to sort of combine together to present to you today, which I hope in a way which was very informative. And just to simply say that, just reflective of how busy and exciting things are in myeloma now, my chief and mentor, Dr. Anderson, makes my travel schedule look like it's A to B. So that's just reflective, I think, of the field. But in an effort to make sure I could be here with you today, we really did try our best to get here in a way that made sense. And I'm especially grateful, actually, to Marek and Jacob for helping me get here, which was great, just to acknowledge their support. So it's my pleasure to follow David with giving you an idea of how we advance the management of relapsed and refractory disease, because as David alluded to, once initial treatment followed by intensification, consolidation and maintenance fails the patient, the question then becomes, what do we do? And I was very interested in a point that David brought forward, which is the duration of maintenance. And to echo some of the key points he made, one of the vital issues in terms of understanding maintenance is what does it then leave you when the patient inevitably relapses. And in reality, David, that was one of the reasons why we kept things relatively short in the IFM Dana Farber trial, was because it's early versus late. We wanted to have the ability to add something or bring back something for when the patient relapses. So that was one other factor in our thinking about duration of maintenance. So I think this is a perfect sort of segue into my discussion today. So what I'm going to do, I think, do I hit this or how do I just
put here?
Oh, I'm sorry. Okay, perfect. Thank you very much. So what I'm going to do is just give you the natural history of myeloma. I think everybody's pretty sophisticated in the audience and understands this. I think thank you very much. The important message here is that active symptomatic myeloma followed by treatment, as alluded to by David, is where we seem to be getting the mileage in our benefit from our combination therapies. This is where the impact on survival is being made. And as David mentioned, once you're in the relapsed refractory setting, managing disease becomes very much more difficult. I think, as David mentioned as well, a couple of key milestones to bear in mind is that with the advent of novel therapies, really the therapeutic paradigm has changed. But I think it's very sobering to remember that in the previous half century, very little really happened except for the advent of autologous transplant and, of course, the landmark work with melphalan. But having said all of that, what I hope to impress upon you is that we are not just dealing with these three drugs now. We fortunately have a whole second generation of drugs coming, which I think will allow us to still take full advantage of these three key drugs up front, and then at the same time have plenty in reserve for our patients. Another key point as well, biologically, with this disease is what we call clonal heterogeneity. And that means that disease doesn't just vary between patients, but it varies within a patient. And what we're beginning to recognize is that you can revisit these classes of drugs at relapse in a way in which you can restore responsiveness. And so the justification for new and novel combinations of newer agents clearly has a biological rationale as well as a practical one. I'm just going to go back very briefly to this. This obviously just sort of illustrates the point about the options that we have in the US for our patients, recognizing this isn't available to everyone, but is the key construct here is that you can use these drugs up front and then revisit them, and we've already heard so nicely from David about transplant and maintenance. I'm not going to go over the more recent data. David touched on it very nicely from Shaji and Dr. Brenner, but I did want to show one slide from Shaji's trial, which is here, which is that if you look at overall survival from relapse, this is the Mayo Clinic study that David mentioned. In fact, exposure to novel drugs is key in terms of improving outcome. In a cohort analysis from Shaji's study, he showed very nicely that if you got novel drugs, you did better than if you didn't at relapse. A couple of few points about biology, because I do think this is always worth revisiting. The critical construct here is the sophistication, obviously, of myeloma, but critically the interaction with the microenvironment. And to recognize one very important point, we think of the bone marrow stroma as an intimate and anatomically proximal environment to the cortical bone. But I want to make one key point. Whilst they may be anatomically proximal, they are functionally distinct. Cortical bone disease is distinct from the marrow milieu. And as the questioner asked very nicely earlier, extramedullary disease, extraskeletal extramedullary disease is also a different milieu. But I would suggest to you that the same fundamental principles that underpin how we target disease based in the marrow are going to matter in how we target both cortically based disease as well as extraskeletal extramedullary disease, and that our better understanding of how myeloma interacts with its microenvironment is going to be fundamental as we go forward. A key point is that our drugs and how they work is because they work on multiple sites. And I just want to emphasize that point again, because obviously in the world of CML, for example, and other hematologic malignancies where single targets can be rapidly exploited, the same is not necessarily true in myeloma at all. And it's no surprise that lenalidomide as an immunomodulatory agent is able to hit multiple targets. One key point I want to bring out is the effects it has on the immune system, and in particular cytotoxic T cells, and indeed at the same token the effects it has on antigen-presenting cells, as well as effects within the microenvironment in the marrow predominantly. Bortezomib, obviously, and the proteasome inhibitors as a broad class also have multiple effects. One key point to also emphasize as we think about this agent in the relapse setting is that unlike perhaps the immunomodulators, this drug and drug class is particularly effective in bone disease as well. So we've heard already about induction, transplant, consolidation, and what I'm going to talk about now in the context of relapsed refractory disease is the role of combinations, how these, in my view, are superior to single agents, and of course touch on new drugs and clinical trials. What's the definition for relapsed and refractory myeloma? Just a take-home point to share with you. This is from a consensus paper published in Leukemia a couple of years ago, but important to understand the differences between relapsing disease and relapsing and refractory disease, and how these are defined in the clinical trials. The critical point is that relapsed and refractory myeloma is disease that's actually progressing on salvage after relapse and either on treatment or within 60 days of the completion of therapy. A couple of other practical points: when to start treatment in relapsed refractory myeloma. I think these are reasonable consensus positions, again derived from an ASH FDA roundtable at which leaders in the field came together to bring up a series of recommendations, and these were the recommendations that came from the relapse committee about when treatment should actually be initiated. And then in the interests of time, what I want to focus on is basically what choices one might make at certain times. Very importantly, when you think of disease, remember how to assess the aggressiveness of relapse, to determine whether this is relapsed and refractory disease, which almost always tends to be much more ominous than primary relapse. High-risk disease, remember, can change. This is not just disease that, you know, if a patient is newly diagnosed and has high-risk disease, that's obviously very ominous, but recognize that patients with standard risk can go on to become high risk as their disease evolves. Again, this concept of clonal heterogeneity within the patient. And then I think very important is you think of drugs that you use in the relapsed and relapsed refractory settings. Toxicity considerations become key, such as the presence of peripheral neuropathy, thrombotic risk, myelosuppression, and so forth. A couple of points to make around those patients with relapsed and refractory disease with particularly a poor prognosis. A lot of these are self-evident, but a couple of points to make. ISS staging, we used to think only applied at diagnosis. It actually applies at any time in diagnosis, at relapse, and in the relapsed refractory setting, with increased beta-2M and serum albumin always being useful. This concept of clonal heterogeneity and evolution of disease over time is emphasized here so that you can always remember to retest your cytogenetics, re-examine your fish. Remember renal dysfunction. If patients live long enough with myeloma, they almost all develop it. Similarly for extensive bone disease, and we've already heard so nicely from the questioner about extramedullary myeloma, and I would completely echo her points. The good news is that we have newer technologies that can help us in this regard. And very importantly, as we think of prognostication in these patients, we have a number of new and exciting tools, such as gene expression profiling, that are obviously in the research arena, but offer us the hope of being that much more able to specifically identify who will respond and who will not to specific cocktails. I just show these slides to you just to give you an idea of the value of PET-CT imaging. This is actually from a paper that Keith, myself, and Hezus published a couple of years ago, and this is actually from Keith's practice, a patient in Keith's practice. But just to illustrate the value of PET-CT in this patient, basically, as you can see, this retroorbital disease was absolutely not anticipated clinically and became evident on this scan. This is actually a patient of mine who had minimal liver dysfunction, interestingly enough, and was post-transplant. And in this context, although he originally had IgA isotype, he actually had minimal paraprotein increase. And I'm sure, David, you're seeing this. You see this more oligosecretory picture after successful transplantation. And then when disease progresses, it can be quite subtle. Now, obviously, the liver function abnormalities were the clue in this poor gentleman, but the bottom line is, as you can see from our PET-CT imaging, really quite dramatic appearances. He fortunately did respond to a combination therapeutic approach of proteasome inhibitor, immunomodulator, steroid, and chemotherapy, 4 drugs, but unfortunately, it wasn't very prolonged. And emblematic of the challenge with this disease, this poor gentleman has subsequently passed away, but nonetheless did enjoy initial responsiveness after previous intensive therapy. Now, in terms of new tools, this is a gene microarray from my colleague Dr. Nikhil Munshi, and Nikhil is, and other investigators are actively exploring this, but this actually is kind of very interesting in my view. It's from patients who'd been exposed to bortezomib and dexamethasone on a series of clinical trials, and what you can see here is microarray for predicting for non-response versus response. And I show this as an example of how this tool may become more and more refined going forward in helping us predict who benefits from what. And you can see why this is so important, because in the relapsed refractory setting, you may actually have less of an opportunity to engender a response than you may in the upfront setting. So I would argue that gene expression profiling becomes actually more important, arguably, in the relapsed refractory setting than in others. This is a simple case to illustrate the construct of how induction and consolidation with maintenance, and it's rather nice because it kind of very much echoes the case that you just described, with an excellent approach up front. In this particular case, VTD. The patient had an excellent response, a nice interval, and then relapsed on thalidomide maintenance. And basically, the question is, what would one then do? And in fact, in this particular case, this patient was successfully salvaged with RBD. But you see my point about how this sort of strategy would be very typical in this setting. This is actually from Heinz Ludwig, a very useful paper that I would recommend to you if you haven't seen it, published in The Oncologist last year. And it gives you a nice algorithm. And this actually I deliberately included in my slide set because it provides you with a very European flavor to the options that you may have. And again, just gives you, and in the interest of time, I'm not going to go through all of these, but suffice to say, just to bring to your attention this particular reference, because I think it's very useful and will echo what we discussed this afternoon. So the points to sort of emphasize now: single agents versus combinations, duration of treatment. Should we do a fixed number of cycles and then keep things in reserve, or should we treat until maximal response, or indeed should we continue therapy until progression? Clinical factors when choosing therapy for relapse disease. I've already touched on this, but comorbidity is important, time from previous therapy, mode of drug administration, the risk profile we've touched on, and then I do want to mention, to echo some of the points made by David, the potential role of second transplant, and also arguably in this setting, what role may there be for allotransplant. So, relapse following autologous stem cell transplant. Is there a role for second autologous transplant, and is there a potential benefit to an allogeneic approach if there is a matched sibling donor available? Well, a couple of things to make. I think as we mentioned, if you relapse after autologous stem cell transplant, 4-year overall survival for early versus late is essentially the same, but the important message here, and this is from various references, but the important message is here is that if you have a reasonable progression-free interval from your first autologous transplant, there is data to suggest that especially if it's beyond 3 years, certainly, and arguably between 2 and 3 is a grey area, that a second autograft in the appropriately selected patient is quite reasonable to consider. I think the allogeneic setting is more controversial now, with the results of the CTN trial that David touched on being less than impressive, I think. Having said that, I do think this is an area that requires continued study. I think what we haven't seen in allogeneic transplant to date is the full impact of novel therapies and how novel therapies could arguably improve allogeneic transplants in a way in which we could see better outcome for the select subgroup of patients in whom it would be reasonable to pursue. So I think allogeneic transplant should always be considered in the context of a clinical trial, but that being said, I think to abandon it going forward at this point would be wholly premature. A couple of things about single agents versus others. This is again published data, so in the interest of time I'll be quick, but suffice to say we see respectable response rates from single agents in this setting, although now with the integration of novel therapies up front, I would argue that the role for single agents in salvage is arguably becoming limited to a relatively select subset. And the reason for that is going to become obvious in the next several slides. First and foremost, that the combinations clearly engender remarkably higher response rates, including high-quality response rates. And this is a whole series of slides, again, the references comprehensively summarized here, which show you that the combination of drugs in this setting is clearly more active. And these are, not response rates for newly diagnosed, of course. These are for relapsed and refractory, and I would say are really quite dramatic, and certainly emphasize, I should say, why I think we are becoming better at salvage strategies. A couple of points to make. Lenalidomide-based regimens, of course, have become, certainly in the US, a standard in the relapse setting, and in fact have shown activity regardless of prior transplant or not. And very important, even with prior thalidomide exposure, clearly are active. And critically, and in contrast to thalidomide, lenalidomide does appear to be active even in the face of adverse cytogenetics. One important point to make is that whilst lenalidomide is not an activator of the osteoblast in the way that bortezomib is, it is an impotent osteoclast inhibitor in that regard. Now, a few points about toxicities from lenalidomide. Myelosuppression is important to remember. Thromboembolism is a challenge, but again, with the appropriate use of prophylaxis, is highly manageable. One side effect we are seeing, particularly in the absence of steroids, is rash. And we do see rash also after transplant when we try to use this drug as a maintenance strategy, as a monotherapy. Be very interested perhaps in the question and answer session we can touch on people's experience here, but we are actually developing a desensitization protocol specifically for this, because we are seeing an incidence of rash in about 10% of patients after transplant, which is no small number actually, and desensitization does appear to be feasible. So that being said, it's an important consideration. One other long-term side effect with lenalidomide is this sort of irritable bowel. Patients develop this chronic sensitivity. It's almost, as I say, like a spastic colon associated with diarrhea. It's manageable, but can be very challenging to patients in terms of quality of life. Now, what about bortezomib-based regimens? Well, I think people are very familiar with this data, so again, I'll move through it very quickly. But suffice to say, it does appear to be a drug of choice in renal disease, and also it does have this potent anabolic effect in bone, which makes it very attractive. What are toxicities? Well, I think the biggest challenge, bar none, with bortezomib is peripheral neuropathy. Gastrointestinal dysfunction can also be a challenge, as can be fatigue. Rash is actually relatively uncommon with bortezomib, and the thrombocytopenia, in my experience, is very manageable and transient. Very rarely, if ever, have I seen bleeding associated with its use. Now, in contrast, I think peripheral neuropathy remains our biggest side effect challenge to date. In this regard, obviously there are a number of strategies, but the most important is dose reduction and schedule change, and I'm going to come to the sub-Q route in a moment. What about symptom control? Well, I think the role of analgesics and the management of neuronal pain is key. We at Dana Farber, with our excellent nursing team, are big fans of supportive care. And basically, with the caveat that one must avoid supplements on the day of bortezomib administration, we've been struck by the benefit of multivitamins and certain supplements that can help, and very importantly the use of emollient creams which are entirely without toxicity, such as cocoa butter and things. No side effects with that, only benefit, and used rigorously and religiously, they in our experience can be helpful. Do we have prospective randomized data to support this? No. But we do have prospective information from single-arm trials that suggest they may be beneficial. However, more scientifically based and more rational, arguably, is the IV versus sub-Q story. After some initial work by Philippe done in Nantes, which revolved about a very interesting story, actually, which I will share with you because I think it's worth it. This actual idea arose because we had originally discussed the pharmacokinetics of bortezomib with Julian Adams at the original time that we were developing bortezomib clinically. And the argument had been, well, if you try to eliminate a Cmax effect, could you actually reduce neurotoxicity? So the argument was put out there some time ago, but was actually put to one side because there was a real concern that if you went to a longer duration of administration, be it IV infusion that was slow versus the sub-Q route, that you might actually lose potency. In other words, you might lose effect. Well, Philippe came at it from a very different standpoint. In Nantes, one of his nurses accidentally administered a cycle of bortezomib to a patient subcutaneously, not IV. Now, in the United States, that would end in the doctor being fired and the nurse being disciplined. In France, it was the trigger to actually an exploratory trial. An enormous credit to them, because the patient not only tolerated a treatment very well, but she actually responded. So a phase 1 study was done by Philippe, or for phase 2 I should say, because it wasn't dose increasing, but it was actually designed to test this in a small number of patients. It's been published, and he showed very nicely that number 1, could you preserve activity, and number 2, was there minimal toxicity. And Philippe has now validated this in a large phase 3 trial presented at ASH just a few months ago, in which he used a non-inferiority design, 222 patients with a 2-to-1 randomization of basically sub-Q versus IV. And in patients who received more than 4 cycles and achieved less than a partial response, they allowed in both arms the ability to add dexamethasone at the classical doses that were developed with the Summit and CREST studies. Now, these were the results that were seen, as you can see, almost identical, with no significant differences in the quality of response for both arms. And very, very importantly, and this is the key construct, was that in fact the rates of significant neuropathy were markedly reduced. A more than 50% reduction in the rates of grade 3 neuropathy, and an approaching 50% reduction in the rates of grade 2 neuropathy. Now, most of us in the field are not too uncomfortable about grade 1 neuropathy, but grade 2/3 becomes a problem. And to see this sort of reduction in the rates of neuropathy is, I think, very, very striking and important. In terms of other side effects, apart from lymphopenia, which was also, interestingly enough, much lower in the sub-Q arm, there were no other significant differences. For example, the thrombocytopenia in the sub-Q group remained the same that it was in the IV group. And that suggests to me that the thrombocytopenia is mechanistically different to the effect of peripheral neuropathy and lymphopenia. And one of the most interesting aspects of this trial was in fact the pharmacokinetics that were done. And what it showed conclusively was actually that the Cmax effect is the difference. The area under the curve is the same for both sub-Q and IV. It is the Cmax effect of the IV that does appear to contribute to the peripheral neuropathy signal and to the lymphopenia. But obviously the absence of differences in other side effects makes that very interestingly the key aspect of why this approach is so much better. So on the basis of that, a filing to the FDA has gone in for sub-Q administration. In the next several months, it's anticipated that they will adjudicate upon that. But I know, for example, David's group have moved to the sub-Q route. We're in the process of doing the same thing. And I know other European groups have moved more quickly. Okay, so let's get back to combination strategies. This cartoon here is a simple rationale for how combination strategies make sense in myeloma, and the message here is simply dual apoptotic signaling, and that in fact as we put these combinations together, it's not a matter of simple empiricism, it is actually a matter of derived science from the bench. This is a summary of a large body of work from a number of laboratories, but essentially shows you that immunomodulatory drugs classically work primarily through the intrinsic pathway. The extrinsic pathway, however, is modulated both by glucocorticoids and proteasome inhibition. And whilst both IMiDs and proteasome inhibitors modulate NF-kappa B, there is a strong rationale for how these drugs then in turn modulate cytotoxic therapy. But the message here again, sort of right, left hook, Army, Navy, Air Force, however you want to put it together, but there is a rationale to the combination of these drugs through dual apoptotic signaling. So on that basis, we've got triple and quadruple lenalidomide and bortezomib-based combinations to share with you. These are remarkably high response rates, favorable toxicology profiles, and they basically reflect the fact that these various combinations can be pulled together. So when one thinks of patients relapsing and becoming refractory, think combinations, and think combinations that are rationally built around proteasome inhibition, immunomodulatory therapy, cytotoxic therapy, and glucocorticoids. I just want to spend a little bit of time on the lenalidomide and bortezomib combination. This is from our phase 1 study, and I just want to bring to your attention that in this phase 1 trial, our overall survival was 37 months, and this is in relapsed refractory patients. So we are very pleased with this, and obviously the confidence intervals here are fairly broad because it's a phase 1/2 experience essentially, and it was in over just 35 patients. But having said that, to see in a phase 1 trial in relapsed and refractory disease an overall survival of 37 months tells you two things. One, the combination is active, but two, it's well tolerated, because no combination that's not well tolerated will generate for you that sort of survival. Okay, so we would therefore postulate that the immunomodulatory and proteasome inhibitor-based combination is a backbone that we should consider in myeloma, and the very important point is that you can add to it with next-generation drugs, monoclonal antibodies, and small molecule inhibitors. Here are a number of examples, and the important message here again is just as we made such progress moving these up front, now we have coming into the relapsed refractory setting a veritable constellation of new drugs coming through under study, and I'm going to spend a little bit of time on each. So where are we going? Next generation novel agents. In the interest of time, I'm not going to go through every one of them, but I want to share with you data on second generation proteasome inhibitors, third generation IMiDs, histone deacetylase inhibitors, AKT and mTOR inhibitors, monoclonal antibodies, and touch very briefly on some new/old chemotherapeutics. Very quickly, I think everyone is familiar with this. Second generation proteasome inhibitors, some very exciting new compounds. Carfilzomib is the most advanced. MLN9708 is an oral boronate peptide that is basically an analogous to bortezomib but with much more favorable pharmacology. NPI0052, like carfilzomib, is an irreversible binder of the proteasome, but it is from a different class. Whereas carfilzomib is an epoxy ketone, NPI0052 is a selenospora-derived molecule. It's in the beta-lactone class and is quite functionally different. SEP18870 is another boronate, which is reversible just like bortezomib. The point is that these have different activities across the proteasome, respectively. By far the most advanced proteasome inhibitor under study in the second generation setting now is carfilzomib, and I want to share with you data from the 004 and 003 studies. Suffice to say that these studies have shown impressive activity both in bortezomib naive and bortezomib treated patients. Very importantly, treatment emergent neuropathy is significantly lower than seen with IV bortezomib. In the 003 trial, which David's partner, David Siegel, presented, I think, extremely well at the ASH meeting in December. And what David showed so nicely was the bottom line here, that if you looked at bortezomib refractory patients, there was a response rate of 17% with durable responses seen. In bortezomib refractory and last line, this appeared to be sustained. And in fact, if you had less heavily pretreated patients, the results were also very impressive. Very importantly, peripheral neuropathy was also low in this study, supporting the role that this drug is much less neurotoxic than its first-in-class bortezomib counterpart. And I think what we will see in the future is that carfilzomib, particularly in combination, will come forward. One of the most exciting combinations is with lenalidomide, and that trial itself is in fact the approval finding study for this compound, where carfilzomib is being combined with Revlimid and dexamethasone versus Revlimid and dexamethasone alone. So we'll watch this space. I think you'll see some very exciting data in the near future. Now, what about third-generation IMiDs? Well, our favorite is pomalidomide. Again, it's a pleasure to be here with David for lots of reasons, but not least of which, actually, the pomalidomide studies in the relapsed refractory setting have been led by ourselves and Hackensack. And basically what we have shown here, and I'll come to it in a little bit more detail in a moment, is a very promising activity in the relapsed refractory setting. By way of introduction, however, I want to share with you this data showing very encouraging response rates even in lenalidomide and bortezomib refractory patients. Why might this be? Well, actually, pomalidomide, if you like, is the best of thalidomide and Revlimid put together. Biochemically, that's literally what it is, and clinically, that's what it seems to be as well. Preclinically, it used to be called IMiD-1, and in the laboratory, it is the most potent of the IMiDs, over and above thalidomide and lenalidomide. So the preclinical data actually does support what we are seeing in the clinical setting, which is that POM is able to overdrive resistance to lenalidomide, resistance to thalidomide, and very excitingly, also resistant to bortezomib. This is data from Martha Lacey, published in the JCO a couple of years ago now, in which she shows this very nicely. And in our own experience, which is the phase 1/2 study I just alluded to, in partnership with David at Hackensack and a number of other centers across the country. This is the design. We did a phase 1 portion first, and now we're in a large randomized phase 2, which has recently been completed. I want to share with you the phase 1 data, but just to show you that we did see evidence of a dose-response effect, and that very importantly we were able to define an MTD which was at 4 milligrams in this heavily pretreated, very sick population. But what I think is just so important to appreciate is that we saw a single agent response rate of POM alone of 18%. Remember that, because that's very similar to what was seen with carfilzomib in the same setting with admittedly low-dose dex and carfilzomib, but just POM alone in this setting. The important message, though, is that these were durable. Now, when then you add to POM dex, actually things improve. And if you look here, this is in our phase 1 evaluable patients. The PR rate is solidly 25%. The MR or better is 50% in this very rigorously defined relapse and refractory population. And what's really important is that the progression-free survival is encouraging at approaching 5 months, actually slightly over 5 months. And what's really interesting, and this is a key message, is that the median overall survival in this relapsed refractory population actually exceeds a year. And I think that in this population is very important. Okay, so future directions of this study are illustrated here, and we're very hopeful we'll have an accelerated approval for this combination soon. Now, what about other new drugs? Well, I want to touch very briefly on histone deacetylase inhibitors. The science is summarized here in this slide, and basically there's a multiplicity of the way these deacetylase inhibitors work, with a lot of downstream effects that make it, again, very attractive as a class of drugs in the treatment of myeloma. Again, it fits our bill. It's a drug class that hits multiple targets. It's not just doing one thing, but multiple things. Now, in terms of one of the most specific aspects of this drug that make it exciting, it's on this slide, and I'm sorry that it doesn't project very well, but suffice to say, when you inhibit the proteasome, one of the most important pathways by which the myeloma cell compensates is through activation of the agrosome. And what's particularly nice is that panabinostat, voronostat, and other histone deacetylase inhibitors specifically inhibit the agrosome, and so are a rational combination to combine. If you look at histone deacetylase inhibitors in terms of their activity, it's summarized here. There's a lot of references, and again, not to overwhelm you, but suffice to say there is some evidence of minimal single agent activity, but when you combine it, things dramatically change. And that's an important message in new drugs in myeloma, is beware that single agent activity doesn't have to mean you have to have 25–30% response rates. If you see tolerability with stable disease and also minimal response, provided the scientific rationale is strong, it's very likely that the combinations, again, provided the science is behind it, will work. And this is an example of just that. If you look at this is bortezomib refractory patients, a 60% MR or better seen in this study led by Jesus San Miguel and presented at ASCO last year. Whoops. Now, I just want to touch very quickly on the PI3 kinase AKT-mTOR inhibitors in myeloma. Perifocine I'm going to talk about, but just to stress that there is everolimus and temsorolimus coming through the pathway, and these are the references, and essentially some very exciting activity with the two. The rationale behind AKT inhibition is summarized here. Perifocine downstream inhibits AKT, and as you can see, AKT is a major pathway by which resistance to bortezomib is modulated, and if you combine perifocine with bortezomib in this in vitro model, you see significant and synergistic activity. This does translate into the clinic. This is our phase 2 work that has actually just been reviewed favorably by JCO, and so is anticipated will be in press soon, and basically shows an encouraging survival in, again, this very sick population, and at the same time encouraging response rates and time to progressions. Again, as I've mentioned, I want to stress this in refractory patients as well. So median overall survival in this relapsed and refractory population, 22.5 months. And if one drills down to the refractory population, you're seeing here in this large phase 2 study, phase 1-2 study, I should say, really quite encouraging data. And a phase 3 is ongoing, and I understand that Artur, you're part of this phase 3, which is great, great to know. I want to close by touching on one of arguably our most exciting monoclonal antibody, elotuzumab. I want to especially acknowledge the phase 1 work led by my colleague Sagaloniel in bringing this forward. These are the results of our phase 2 study presented at ASH in December. And very briefly, just to bring to your attention that elotuzumab targets by being humanized as a monoclonal antibody, a cell surface glycoprotein CS1 that is very specific and highly and uniformly expressed on myeloma, and basically on that platform has been shown in a xenograft mouse to be a potentially important target. And it was particularly interesting because in the xenograft mouse as well, Saga modeled very nicely the enhancement of anti-tumor effect with lenalidomide. This is our randomized phase 2 study schema. What we were trying to do here was optimize a dose and schedule to go forward in phase 3. And to cut to the chase, we showed that at 10 milligrams per kilo, you saturated the target as well as you did at the higher dose. The important point being here that less is more, and fusional reactions with elotuzumab can be a challenge, and so we've taken forward the 10 milligram per kilo dose, particularly with an enhanced pre-medication regimen. And what was really exciting is illustrated here. Response rate, PR or better, is 81%, with 37% VGPR and CR, which is remarkable for a 3-drug combination. And a large randomized phase 3 is imminently going to be underway. Very briefly, bendamustine in myeloma is an important new chemotherapeutic, certainly in the US, less so here in Europe. As you know, it's been around in Eastern Europe since after the war. But the bottom line is that it's a drug that we feel may have some mileage as an alternative cytotoxic in combination. My experience with it has been fairly limited, but off protocol, I've been impressed that it can be active. I do think, however, it still has some of the challenges of conventional chemotherapy. So I want to summarize by just saying new approaches in relapsed refractory disease have really, I think, transformed our ability to salvage patients, recognizing, as David mentioned, that even in the era of novel therapies, once patients have run out of options from immunomodulators and proteasome inhibitors in the first or first generation sense, we face a real challenge. I think the important point is that participation in clinical trials for this population is an absolute key priority for all the reasons that I just showed you. I think in terms of future directions, it's actually, to my view, looking very optimistic. And in that regard, we have an important balance of combinations versus toxicity, but I think we're really getting there because, as you can see from the combinations that I've just alluded to, we're seeing remarkable activity with actually extraordinarily manageable side effect profiles, generally speaking. And if one thinks that second-generation proteasome inhibitors are halving rates of neuropathy, if you think that all the treatments I've just showed with you are all outpatient, I think we mustn't forget that's real progress. We're not talking about 4 or 5 transplants. We're talking about outpatient regimens that allow patients to have an excellent quality of life. And I want to conclude by sharing with you one case. David knows this person, I think, of old from previous presentations, but I always love to update, particularly people who don't necessarily know him, because he reflects, I think, what this is all about. He's a lovely 66-year-old gentleman who's diagnosed actually some time ago, back in 1996, age 52. And at that time, he could hardly be argued to have good prognosis disease. Stage 3A kappa light chain myeloma, 13 deletion positive. He got very traditional chemotherapy at that time. He got thalidomide after first relapse, which was then massaged with Biaxin and dexamethasone to try and augment response. He went on to allogeneic transplant from his sister with donor lymphocyte infusion planned, but unfortunately he progressed already within 3 months of his allo, and he came to us to receive bortezomib monotherapy in 2002. Interestingly enough, his marker, his number on the trial was 007. Now, you won't be surprised to hear that his name, actually, he doesn't mind me sharing it, is James Bond. So this was pure accident. We actually gave him this number because that's the number that was up on the trial. He was called James Bond, so we were very confident that he was going to respond, and actually he did. He had a beautiful response to bortezomib, and basically after that, completing his therapy, he then went on to voronostat, which he had stable disease on as part of a phase 1 trial. He then progressed in 2004, but remained on lenalidomide monotherapy as a single agent, the so-called 014 study, which we published a few years ago now, and has maintained a very good partial response ever since, so 2004. And in fact, all the way through, we were worried that he might progress in December of 08. He actually hasn't. We've actually increased his lenalidomide dosing. We didn't have to go onto a combination strategy, and he's remained extraordinarily well with continued remission on lenalidomide. As he's quoted in Newsweek from a few years ago, I'm just glad to be above the divots. And this is a picture of Jim playing golf, which I think is rather a nice one. He sends me these regularly. This is then a picture of him from about 1.5 years ago. And I just want to emphasize this because this is his son, this is his lovely wife, Kathy, this is his daughter-in-law. And as Jim said to me, to be here, 2 years ago now when this wedding took place, when he'd come to us in 2002 with essentially end-stage disease, is remarkable. And then he sent me this picture most recently, this is Jim on his bicycle raising money for new drug development in myeloma. This is for the American Cancer Society. And this was the quote: "If you guys didn't work together and as hard as you do, I wouldn't be here." And there he is. So I think he embodies so much of what we're all here for, frankly. I want to finally close by acknowledging the remarkable partnership that has built all of this and the progress and hope that has come from it. And very, very importantly, acknowledge all the investigators involved, a number of whom are in this room, in fact, not least David and Arturo, but others, which have made this all possible. And I want to finally close by acknowledging my own team, and in particular, my chief and mentor, Dr. Ken Anderson. And I'll stop there. Thank you very much.
Thank you. Really great talk, Paul. Thank you. And I would like to ask you about the dose of pomalidomide.
Right.
And this is some trials, of course, but what is your opinion about this?
It's a great question, Artur, and I'm glad that you ask it because in the relapsed refractory setting, 4 milligrams is clearly the maximum tolerated dose. However, there is a question as to whether or not 2 milligrams is as good as 4. And at the ASH meeting, Martha presented her data from Mayo Clinic. And what was interesting to me is that whilst the study wasn't necessarily adequately powered to precisely address the question, what was clear is that actually the median duration of response for her study had not been reached at 4 milligrams, but was reached at 2. So I think in terms of durability of response, we do have evidence of a dose-response effect in her study, even though at the conclusion of her discussion, she didn't allude to that. Xavier Loulou in the French study also had explored this question, and I think the results from his trial seem to suggest that probably more was better, although again it wasn't conclusive. In our own trial, with this very well-conducted phase 1 piece, I think we did see evidence of a dose-response effect. At the 5 milligram dose group, we saw a higher response rate. Having said that, I think the message is 4 is probably optimal, but you can respond well at 2. And if you think about it, that's entirely consistent with what we know about thalidomide and lenalidomide, that patients respond at 10 and 15 of lenalidomide, but 25 is an optimal dose to think about going in, recognizing that you can go lower. Exactly the same is true with thalidomide, but the biggest difference there being that thalidomide side effects are cumulative, not just dose-related. So I think that with POM, 4 in the relapsed refractory setting is the MTD. In less heavily pretreated patients, in first relapse, for example, my inclination is that we still have the opportunity to explore dose. And I would not be surprised if 5 in that population would actually make sense. And up front, who knows? But I think right now, 4 in relapsed refractory with the caveat that 2, if a patient is not tolerating 4, or even 3, can be reasonably explored.
And another question about oral proteasome inhibition.
Right.
Because you mentioned about this, and it could be interesting in using patients.
Yes. No, I think it's a great question. I mean, one of the biggest challenges with obviously the field is the question of making things more convenient. I think one important point about proteasome inhibition, however, is that I still think we need to monitor our patients very carefully. So I think no matter how much we go to the oral route, especially with combinations, seeing patients regularly matters. But as David and I were discussing earlier, if a patient can just pop in and see you and leave in half an hour, that's a much different experience than staying for 3 hours to get IV therapy. So I think the oral proteasome inhibitors have a lot of legs to them, a lot of potential value. MLN 9708, so far we've been very pleased with. Minimal neuropathy to date. Skin rash, interestingly enough, it has a different distribution pattern than IV boronate peptides. And we've seen activity. But I still think it's early days. So assuming that to be the case, I think oral boronate peptides as a proteasome inhibitor in combination probably have a lot of promise. We've had great experience so far with our upfront study. We've got a combination upfront study, MLN 9708, lenalidomide and dexamethasone, and we've enrolled 3 patients in the first cohort, and they've all done extremely well. So we think it's exciting.
Another question, you didn't mention about radiotherapy in relapsing refractory myeloma. Have you any experience with this?
Oh, absolutely. And again, it echoes the question from your colleague. Radiation therapy is very important to isolated disease and even sometimes to less isolated disease. But radiation therapy we use adjunctively all the time. One of the interesting biggest challenges we're facing now is leptomeningeal spread. We're starting to see patients with CSF involvement, and that is a big challenge. The literature supports craniospinal irradiation, which I have not found particularly helpful. Intrathecal therapy is a challenge. David, what you've been experienced with in leptomeningeal disease?
We haven't been giving craniospinal irradiation. We've been giving actually sometimes combination of ARC, thiotepa, and hydrocortisone.
And I was just going to say that's an excellent choice because I particularly like your thiotepa because I think there's no role for methotrexate. I mean, it doesn't have any activity. And I agree with you, ARC plus steroid plus thiotepa. Now, how much response have you seen from it? Because our results have been a bit disappointing.
Responses, none of them are durable.
Yeah, exactly.
It's better than it was in the past, but you're still dealing with 3 to 6 months.
Yeah, I agree with you. Yeah, so I think that, and basically, so what we've used radiation more effectively for is soft tissue disease and for situations like that.
Another question? If not, I'd like to thank you very much.
It's a pleasure.
It's a really great talk, you and David.
It's a pleasure.
Thank you again.
It's a pleasure. Thank you. Thank you very much. Thank you.
Our chief, Professor Skatnicki, asked to express his gratitude for that you found some time in your travel by Europe to stop in Krakow.
No, it's our pleasure.
It was really excellent presentation. So thank you very much. And I think in the name of all of us attended this meeting. Thank you very much.
Pleasure. Pleasure. It's a pleasure.